Good evening, everybody. My name is Gary. Welcome to the Living Well with Gout webinar series by the Arthritis Foundation, sponsored by Horizon Therapeutics. Again, my name is Gary. Let me give you a little background about myself. I will be your special guest moderator tonight. My role is I work with Trend Community as the Senior Community Director. We are a data analytics company that works with the rare and underserved community. We use AI to turn anecdotal conversations into actionable steps for our pharmaceutical partners. The second hat that I wear is that I am the co-founder of the Gout Support Group of America that works to improve the lives of people living with gout through wellness education, empowerment, and community. So our members strive to proactively manage gout and help others identify and manage gout through community. So let's start with some housekeeping items. We will be muting all attendees for this evening. And if you have questions, you can direct it to the Q&A box at the bottom of the screen. We'll definitely try and we actually will reserve some time at the end of the program for Q&A. So look forward to that. That's always my favorite time. Tonight's session will be recorded so that if you would want to check back and look for this program, you'll be able to find it on the YouTube and also the Arthritis Foundation hubs for the webinars. Lastly, you'll receive a survey from the foundation after the event that's going to ask about your opinion. Now, it's important that you fill out the survey for us. We would love to have that for future reference. We use that to better our events. So with that, I'm so excited to introduce our guest speaker tonight. Dr. Baraf is a founder of Arthritis and Rheumatism Associates, the Washington, D.C.'s largest private practice rheumatology group. He's also the founding medical director of the Center for Rheumatology and Bone Research. He retired from private practice in 2022 and currently is special volunteer of National Institutes of Health. Dr. Baraf holds academic appointments as a clinical professor of medical at George Washington University in Washington, D.C., and an associate clinical professor at the University of Maryland in Baltimore. He has served as a principal investigator on over 300 clinical trials in rheumatology, with a particular interest in gouty arthritis. Dr. Baraf was designated as Master of the American College of Rheumatology. And in 2014, he was awarded the ACR's Paulding Award for service to patients and the profession. He is the 2022 awardee for the ACR's Innovation in Clinical Care Award. It is an honor for us, actually for me, to introduce to you Dr. Baraf. Dr. Baraf, take it away.
Thank you, Gary, and thanks for your background story, because I hadn't heard it before, and I have to look you up. If we can have the next, and I want to learn more about your society, and it's really it's quite a journey for many patients with gout who seek diagnosis, and then once the diagnosis is made, to understand how it all works. So let's move forward one slide. There we go. So to me, the hardest part about gout is that it's a condition that needs to be treated lifelong. And the problem is that getting an understanding of why you do what you do, why the doctor recommends what's recommended, is part and parcel to how well you'll be able to comply and how successful that compliance will be in getting you to where you need to be. So I like to think of gout as really two diseases. The first, gout's a metabolic disorder. There's too much uric acid in your system. And it's either, the blood level is either too high because your kidneys don't get rid of it effectively, or it's too high because you make too much uric acid. And we'll get into that, and don't try to read that blurry left side of the screen. So gout is a metabolic disorder, or a disorder of the body's chemistry, and it's an arthritis. It's a disorder that affects the joints. Let's go to the next slide. So first, this is a very common problem. We mentioned it's caused by high levels of uric acid, and it usually presents as severe pain and swelling in a single joint. Half of the patients who have gout will have gout in one of their big toes, and it will be exquisitely painful the first time around, and red and swollen, and putting on a sock, forget about putting on a shoe. Being able to handle the sheets on the bed, on your foot in bed at night, is already a challenge. Over time, it may involve more and more joints. It's seen more commonly in men than in women. We had done a study of 35 to 40 patients with gout when I was a fellow at Duke, and the average age of onset was 28, although books published the average age of onset at 40. Perhaps, as in Gary's situation, it's not the age of onset, but the age of diagnosis. And it affects not 8.3 million people in the United States, but over 9 million people in the United States. Let's go to the next slide. So uric acid is a chemical that is derived from the breakdown of DNA. Remember, DNA stands for deoxyribonucleic acids. And purines are one of the two types of nucleic acids that exist in DNA. And purines break down to uric acid. And the problem with uric acid is that it's not terribly soluble. So think about a glass of iced tea. You put a packet of sugar in and you sweeten the tea, but some of the sugar falls to the bottom of the glass because water can only hold so much sugar. Serum can only hold so much uric acid. And so in individuals who have elevated levels of uric acid in the serum, that uric acid precipitates out as crystals in the cooler areas of the body, particularly in joints, particularly in the feet, and to a lesser extent, the hands. And then as the amount of this uric acid accumulates, you begin to see it in larger joints and sometimes even in organs. So the body does not efficiently get rid of uric acid, and too much uric acid in the blood causes a precipitation of crystals in the tissues, and those deposits of crystals over time lead to the arthritis. So let's go to the next slide. This slide illustrates the two diseases, the metabolic disease and the arthritis. So over a period of years from left to right, you start without symptoms and you have an elevated uric acid. And look at that blue sloping line that goes upward over time. That blue sloping line consists of the amount of uric acid that has settled in the joints and have begun to accumulate because the serum uric acid level in individuals who develop gout is too high. And then that first yellow spike after that curved blue arrow, that's the first gout attack. And then over time, a second gout attack occurs. About 80% of patients with a second attack will have it within 2 years of the first. And then in a shorter period of time, a third attack, and then more attacks. And the thickness of the line designates how long the attacks last. And over time, as you go all the way to the right, you have chronic pain all the time with intermittent flare-ups. But in between the attacks, because if you go to the doctor and you have a big red hot swollen foot or ankle, and they give you something to take care of the inflammation, the pain, the arthritis, but they don't treat the uric acid level. In between each attack, the amount of uric acid that accumulates in your body increases. And this is where there's a disconnect sometimes with primary care doctors, where the uric acid is not addressed, only the joint pain. If you don't address the joint pain, you're doomed to have another attack and many more after that. Let's move to the next slide. So flares are what brings the patient to the doctor because they don't know what their metabolism shows. And typically lab work that's done doesn't include a uric acid. When you go see a doctor for a physical, for example, you sort of have to remind the doctor, hey, maybe I have gout. Have you checked my uric acid level? That's a useful question to ask. So you have to have an elevated uric acid. But as I mentioned with that diagram, before your first attack of gout, you've been accumulating crystals. And in fact, if you have your first attack of gout, and if you put yourself in the Wayback Machine and go back 3 or 4 years, and then literally open up the foot and look at that joint, what you'll see is a caking of crystalline matter on the surface of the cartilage. So the predicate of any attack of gout and any joint pain from gout is over time the accumulation of these uric acid deposits. The pain of an acute gout flare is intense, about as intense as anything we see in medicine. And the attacks, as I mentioned, 50% occur in the big toe, but they can occur anywhere. I've seen it begin in a hand, a wrist, an elbow, a knee. And the pain may last with a first attack for 7 to 10 days and then calm down on its own if you don't treat it, or calm down with a couple of days if you're on a colchicine or an anti-inflammatory medicine or a steroid. And as mentioned, over time, the number of joints affected increases and the frequency of attacks increases as well, as apparently Gary had experienced. Let's go to the next slide. So you can go for long periods without attacks of gout, but you're always accumulating uric acid if you're not on medicines to lower the uric acid. And the accumulation in time may become obvious to the patient and to the doctor because lumps form, soft tissue lumps called tophi. So someone who has tophi, which are really accumulations of uric acid salts in the soft tissues, we call that tophaceous gout. And that's the most severe form of gout. Gout may affect, we're going to go through a few slides, so be ready to push the button, fingers, hands, feet, elbows. Keep going. In that slide, that purple slide, the ankle is swollen and red as well. Move to the next slide. This is a patient who's had many attacks in his feet and also has this accumulation of uric acid in the soft tissues around the great toes. And this is tophaceous, not because of the word toe, but because they're a tophi, tophaceous gout in the great toes. Let me see the next slide, please. And what happens to the bone? If you look at the big toe and the small toe, you see that all the bones that are supposed to be there are there. But if you look at the second, third, and fourth toe, you see that the uric acid is accumulated to the point that the bone has been eroded away, and then there are calcium deposits that have precipitated out into this tophaceous material. So this can be a very destructive arthritis. Let's move to the next slide. These are tophi on the fingers. If you look at this gentleman's index fingertip, that's actually, that white material is actually crusted uric acid salt that's drained from the finger. And you see some other areas, particularly one above that, closer to the last joint in that finger, just under the surface. It looks sort of a pinkish. Or the one in the middle finger, in the middle bone of the finger, you see this lump, but you also see a yellowish, reddish accumulation. Again, those are uric acid crystals under the skin. Next slide, please. This particular patient, by the way, was someone who I said, you've got gout, you need to be on medicine to lower your uric acid. And he said, yes, sure, doc. And then came back 7 years later and his fingers looked like that. They didn't look like that when I first saw him. This is a patient with a tophus on his elbow, a tophaceous deposit. Next slide. It can get really bad. Here's a fellow who's got tophi on his fingers, and he's got this big sack of fluid on his elbow from his tophaceous gout. Next slide. So, why do you get gout? And what are the risk factors for attacks of gout? Well, genetics. Majority of patients who have gout don't handle uric acid properly. Their kidneys don't handle it, don't excrete it, because there are genetic defects in the way the kidney handles uric acid. That's by far the most common cause of gout. About 90% of patients with gout have difficulty excreting uric acid. Patients who have kidney failure or are on their way to kidney failure, they also can have elevated uric acids because they simply can't excrete it, even though they have normal mechanisms in the kidney. The kidney is starting to fail and just doesn't do it. I'm not so sure about the reduced activity side, but exercise is good. I'm not a big believer that diet is the root of all evil in gout. Diet should be controlled in all of us to keep our weight down and keep us fit. But if you treat a patient who has severe gout with diet alone, they will continue to have severe gout. Men get gout more often than women until the menopause. And at the menopause, the rate of women developing gout begins to parallel the rate of men developing gout at that stage of life. Certain medications cause the uric acid to rise. For example, fluid pills, diuretics, particularly hydrochlorothiazide and furosemide. And patients on these medicines for heart failure or for control of blood pressure or for control of edema, of swelling in the legs, may develop elevated uric acids, and over time they develop gout. This comment about pre-existing ailments. We talked about kidney disease, but there are associations. Patients with gout are more likely to be diabetic. They're more likely to be overweight. They're more likely to be hypertensive. They're more likely to have heart disease. They're not necessarily the cause of the gout, but there are associations either with the treatment for those disorders or genetically. Those disorders and gout tend to run together in what's called the metabolic syndrome. The metabolic syndrome has a number of components. Elevated uric acid, also called hyperuricemia, is one of them, but so are diabetes, obesity, elevated cholesterol, kidney insufficiency, and heart disease. This comment about recent certain trauma, if you have tophaceous material, you have uric acid that's deposited in your feet, and you kick a soccer ball too hard or kick a wall or stub your toe, it could precipitate an attack of gout. Other risk factors for developing attacks of gout would be anything that causes the uric acid level to fall, including the medicines we use to lower uric acid, or to rise, including stopping the medicines we use to lower uric acid. Let's move to the next slide, and we'll get into that. I think it's an important point. So what medicines do we use? Well, we treat the arthritis, the gout attack. Even the gout chronic joint pain doesn't necessarily come as an attack. In some patients, it looks just like rheumatoid arthritis. All the joints can be swollen and painful at the same time, and not acutely, but chronically, particularly in a patient who has had gouty arthritis for many years. But anti-inflammatories and cortisone-like drugs and colchicine are all commonly used to control inflammation in gout. And I'm sure there are going to be a lot of questions about that as we get to the end. And then we have medicines that control the uric acid level. And the key to controlling the patient with severe symptomatic and recurrent or chronic joint pain from gout is to control the uric acid. And by far the most commonly used drug is allopurinol, and the second most commonly used drug is febuxostat. And allopurinol and febuxostat are referred to as xanthine oxidase inhibitors they interfere with the production of uric acid. So I mentioned that purines from DNA lead to a breakdown to uric acid, and it stops there in us, in humans. And these two drugs, allopurinol and febuxostat, inhibit the breakdown to uric acid. There are intermediate steps, and during those steps, the chemicals that accumulate are more easily excreted than uric acid, and that's how they work. Probenecid is a medicine, excuse me, that helps you excrete uric acid. Now, I mentioned that 90% of patients have an elevated uric acid level because they don't excrete it well, but 10% make too much uric acid. And those patients are at risk for kidney stones. And about 10% of patients with gout have a history of kidney stones because they over-excrete what they overproduce, the uric acid, and uric acid stones develop. Probenecid increases the excretion of uric acid, but shouldn't be used in people who have a history of stones. And then finally, pegloticase, very interesting drug. I was involved with its development from the very, very beginning. Pegloticase is an enzyme that has been treated with something to keep it alive in the serum for prolonged periods of time. And this enzyme breaks uric acid down to a substance called allantoin. Now, I mentioned man gets gout, and the great apes get gout, but other warm-blooded animals and birds, they don't develop gout because they have that enzyme, uricase, and they can take that insoluble uric acid and break it down to allantoin, which is very easily excreted by the kidney. Pegloticase is a uricase enzyme, and it can lower the uric acid to profoundly low levels and lead to rapid clearing of these uric acid deposits. Let's go to the next slide. You had recurrent attacks of gout. Your doctor says, I'm sorry, but we need to lower your uric acid level. And here is allopurinol. That's the most common scenario in the doctor's office. What's the goal? Well, what's your uric acid to start with? For some, and Gary, I don't know what yours was, but it might be 7, 7.5, 9, 13. What's the point in the serum where uric acid crystallizes and deposits in the tissues? It's 6.8. So if your uric acid is higher than 6.8 and you're on treatment for gout, the treatment's not adequate. The medicine you're getting is not lowering the uric acid enough. If you lower the uric acid to below 6, then you have the ability to dissolve those deposits. And by dissolving those deposits, you pull it out of the areas where it's deposited, and you can eliminate it through the kidney. Or in the case of pegloticase, you just convert all those deposits into something else, which gets eliminated through the kidney. But the key is to get your uric acid low. And the more severe your gout is, for example, if you have significant tophaceous deposits, tophi, the lower you want to get the uric acid. So if the patient is not felt to be in dire circumstances, but have significant tophi, you want to lower the uric acid to below 5. And if you're followed by your rheumatologist for gout, every time you go in, you want to say, what's my uric acid been? And should we check it again? Just to remind your doctor in case your doctor needs the reminding, because you want to know that your uric acid is going to be less than 6 or less than 5. So other ways to manage gout. We talked about diet. You can lower your uric acid 1 point with diet, unless you get your body weight down by a significant percentage. You can lower your uric acid by 1 point by avoiding the foods that are associated with gout, organ meats, and certain vegetables, shellfish. I really don't put a lot of emphasis on diet, except to the extent that I put it on weight. But the other thing you take in that can be very difficult if you're trying to manage your gout is alcohol. This alcohol can cause the uric acid to fluctuate It interferes with the excretion of uric acid, and it is a major risk factor for gout. So maintain a healthy weight. If you need your uric acid controlled, it should be with medicine, not with diet. Diet's good, but diet's not the solution. Everyone should exercise regularly and stay functional. Drink plenty of water, but if you drink 10, 15 extra glasses of water a day, your uric acid's not going to come down that much, and you'll get sick with water intoxication. Just stay well hydrated. And because if you have gout, you're likely to have some of these other problems: heart disease, hypertension, other metabolic disorders, diabetes. You want to get those under control as well. Let us move to the next slide. So these are the foods that one might consider, but my patients really love me because I tell them, no, we're in Maryland, right? And Maryland is the home of crabs. I mean, if you're not a Maryland person unless you're eating, you're going to a crab fest. My patients love me because I tell them, do you want to eat crabs? Eat crabs. Let's just get your uric acid under control, and don't wash it down with beer. Makes a big difference because the patient comes back, and the patient is, and their gout gets better. So if there are things that now, binge eating isn't good, and binge eating will cause uric acids to fluctuate, and the fluctuation can lead to attacks as long as you haven't gotten rid of all your deposits, which usually with medicine takes a few years. Next slide, please. So diet is not the major treatment option for gout. Medication is. Most of the medications for gout, excluding pegloticase, are cheap. They're very inexpensive, and they're very effective. But they're only effective if you're consistent with them, if you take them every day. So I mentioned that when you take a medicine like allopurinol for buxostat, it actually increases the risk of gout in the very short term. And so we usually use medicine to prevent those uric acid normalization flares. And if you give up on your uric acid lowering medicine and you stop it, that will cause your uric acid to rise, and that also will precipitate attacks. So don't stop your uric acid lowering medicines. Don't stop it for flare-ups. Don't stop it because you haven't had a flare in a year. Just keep it going. You're going to need to be on it for life. The only patients I've seen who could stop their uric acid are patients who have had bariatric surgery and lost 40% of their body weight. Perhaps patients of that nature who are severely overweight at some point will do very well with the Ozempic-like drugs. There's a new one that apparently leads to a reduction of 25% of body weight. That will have a positive effect on elevated uric acid in patients who need it. But that's not really the solution for gout. The solution is simple. It's consistency, and it's the use of uric acid lowering drugs. Next slide, please. So if you hit the clicker once, this is a gentleman, a cardiologist from Baltimore who had very, very severe tophaceous gout, as you can see from his fingers. And hit the slide one more time. And these were his hands, and that was his ability to make a fist. And this patient was given pegloticase, and after 6 months, that was his ability to make a fist. And we can go to the next slide. And then we took him off of pegloticase, and we put him on, in his instance, febuxostat. And 2 years after he had 1 year of treatment with pegloticase, that's what his hands look like. So we can have very dramatic effects on the outcome of patients with severe gout. And now I think if we go to the next slide. Yeah, there's nothing more I would like to do than to engage. So let's see what we've got. And Gary, you may want to come on board. And first, what was your story? I'm not supposed to ask the questions you are, but you know.
No, I'd be happy to share. Thank you for that. Very informative. Yes, I lived with gout for since 1994. I was actually walking across campus one day, and my ankle started to hurt, and I had no idea why. So I went home, called up my dad, had a conversation with him. I'm like, "Hey, Dad, I was just walking to class, and my ankle feels like I feel like I broke it, but I don't know what I did." He says, "Gary, I think you might have gout. Gout runs in the family. You know, I have gout. You might have gout. Go see your doctor." So I went to see my primary care physician, sat in his office. Remember, I'm 24 years old, and I sit there and I said, "Hey, doctor, I think I have gout." And I still remember the look in his eyes. He looked at me. He says,
No
"You
way.
are way too young to have gout. You must have done something, right? You probably forgot." And I was like, I still remember that feeling. I was like, yes, I won the lottery. I don't have gout. Dad, you're wrong, right? I went home and my doctor said, "Hey, take a couple pills, whatever. The pain will go away. You'll be fine." And of course, the pain went away and out of sight, out of mind. The pain went away. But 16 years of that, what happened was as the years progressed, the attacks became more and more intense. It increased in severity. And by the time I actually found my voice and found courage to go and demand some answers, when I was diagnosed, my UA level was north of 10. And I suspect that I had been north of 10 for a long time.
Did you
I
have
was
tophi?
diagnosed. I did in my toe and in my elbow. I did, and I was pretty severe. They diagnosed me with chronic gout, and I'm an overachiever. My body is, and the fact that I overproduce uric acid, and and I don't get rid of it well. So I excel in both areas. Um, so um, so when I look back at that. I remember my rheumatologist saying, "Hey, Gary, all we need to do is perform a simple blood test and we're going to find out if you have gout." And I was thinking to myself, are you telling me for 16 years, all they had to do was prick me and measure uric acid and just listen to my story and put the pieces together, like a jigsaw puzzle? And I was beside myself. So we did that test, north of 10, like I said, and I had chronic gout. And I was so stubborn in the fact that my body was so stubborn. I took allopurinol and I also was using Uloric. We tried different medications. I went from 10 to maybe 8, but we couldn't get it down enough, right? And the conversation with my rheumatologist was that, "Gary, we can probably get you under 6 to the point where your body will start to dissolve some of the uric acid crystals that have been forming for years around your joints and whatnot." But I am involved in a clinical trial. It was 2010 Cristexa, which is an infusion. You talked about that medication.
Fibrotics, right.
Yes. That was out stage 3. And my rheumatologist, Chris, said, "Hey, Gary, you might be a great candidate for that." So after asking tons of questions and weighing my options, I said, let's go for it. Let's sign me up. And my experience with that drip medication was that I was on for 9 months. It took me 9 months of treatment, two treatments per month, 6 hours per treatment back then. So it was a high commitment. My attacks were actually increased in the first 3 months of taking the medication. And what I found out was that it's very normal when the body rapidly changes.
Oh,
They
yes.
actually, right?
The flare-ups can be very, very severe with Krystexxa. You lower the uric acid not to 5 or 6. You lower the uric acid to less than 0.1. You lower the uric acid by 98%. And
Yes.
profoundly low, and it's extremely effective. So just 2 points, and then I guess you want to open it up to questions. One is we talked about genetics, and you mentioned your father. This fellow who had such severe hand involvement from his gout, he was a cardiologist and he was originally from the Philippines. And he said to me once his hand started to function, he said, I've got to go home to the Philippines and tell all my friends, because what he's really saying was, because gout is so rampant in some parts of the South Pacific and the Orient, that
Yes.
this is a very, very common problem. It's very common in Hawaii. I know a rheumatologist from Alaska who's opened up a clinic in Hawaii to take care of tophaceous gout. He goes there every 2 weeks, and he has nurses.
Bless his heart. Yeah.
Yeah. So it's genetics plays a big role. Weight plays a role. And the other point, if you want to make a definitive diagnosis of gout, when you have your first attack, putting a needle into the joint, which sounds awful, but not necessarily terrible, particularly if it's under ultrasound guidance, you can pull the crystals out and you can put them under the microscope, and you can see the salts of uric acid under the microscope. It's very, very characteristic appearance. It's one of the few things we can do in medicine that is absolutely definitive and undeniable. So you got some questions.
I do. So now it's time to go into our question and answer time. We're going to try and get through as many as possible. Just a reminder, if we're not able to get to your questions, I want you to go visit the Arthritis Foundation helpline. It's arthritis.org/helpline. And they can help answer questions, guide you through any arthritis questions you have, gout being a form of inflammatory arthritis. So, through your presentation, you mentioned a lot of good information. I want to start with this question. When people look at gout, even doctors, when, they think of gout, they tend to say, hey, it affects men, older men usually, and that's what they typically will focus on. At the Gout Support Group of America, we have north of 15,000 members, and what we're seeing is it's a good spread across. Yes, the majority, maybe 60% or so, are men, middle age, but we're seeing a higher number of young men, young women, and women, as you say, those that are over in menopause are affected with gout. What are your thoughts on this? Do you think it's an environment? Is this something new? Have you seen this?
No. It's estrogens affect uric acid, and so when you go through the menopause, your estrogens drop and your uric acid rises. The other thing that with age is that people tend to accumulate illnesses with age. They accumulate. The other day, my wife must be on 3 meds for blood pressure and something for thyroid and 4 other things. And she creates this pill box, and 3 of her medicines are small, white, and round. And the only way to know what they are is there's a pill identifying program on the web. And she said, why are all the, so the point is that as we get older, we're also on other medicines, like diuretics that can cause uric acids to rise. But it's very clear that gout in one's 20s, 30s, and 40s, that's a male disease. I've only seen 2 women who were in their 30s with gout. No, I can't, I saw a fair amount of gout in practice. But of those 2 women, one I saw while she was recovering from bariatric surgery, 4 joints blew up. And I was not suspecting it. And I tapped the joint, looked at it under the microscope, it was clearly gouty. And the second was a woman who had developed renal failure from acute alcohol poisoning and was in her early 30s. And then had renal failure and had gout on that basis. So it's very unusual to see a woman in their 40s or younger with gout, but not uncommon.
Gotcha.
The other thing about women and gout is that the severity of their disease and the way it presents, the way it manifests, They say women, when they have heart attacks, they don't manifest the same way that men manifest. This is also true about gout. Maybe not as life-threatening a disorder, but it is life quality threatening. Rheumatologists, we add years to the life, not necessarily life. I'm sorry, life to the years, not necessarily years to life. And as you mentioned, this can be very, very disruptive in a life. Women, when they develop gout, don't necessarily develop the red hot swollen big toe. They may develop a lump on a finger that starts to drain white chalky material like that fellow had on his fingertip. Or a variety of other, or they may develop all the small joints in their hands may gradually, slowly become inflamed and sore and stiff and swollen, and they look like they have rheumatoid arthritis instead. So it can be somewhat perplexing in a female who develops gout because it doesn't follow the usual rules.
Interesting. So let's go to this question here. I reflect back on the Gout Support Group of America working with Trend Community. Trend Community is an analytical company. Basically, we analyze online conversations so that we can figure out trends and whatnot. And so in 2022, we did a project together. We factored in and we analyzed about 150,000 comments within that year. And we saw a connection between proactively managing gout. And when I say proactively managing gout, I would say a patient who is working with a rheumatologist or their primary care physician to deal with the cause maybe of or the attack versus reactively managing gout, maybe waiting for a flare to come up and they would go to the urgent care and whatnot. We saw a connection between proactively managing gout and having a more positive effect on their mental stability and mental health versus when they are reactively managing this disease. It actually affects them in a negative way mentally. We saw that connection. I wonder what your thoughts on that and just kind of get your pulse on that finding. What do you think?
Well, two things. Obviously, the use of uric acid lowering, well, there are a few things actually. The use of uric acid lowering medicine, it takes a while to work, but being consistent with it, proactively interacting with your patient to say, are you still taking your medicine? And your uric acid was a little higher. Was it because you stopped the medicine or ran out? Or is it because we're not giving you a high enough dose? So getting the patient to work closely with the caregiver is important. There was a study in England that you're probably familiar with where they had nurse practitioners managing gout according to a protocol versus standard of care with the primary care physician. And the nurses did much better than the primary care doctors who weren't following script. Much, much better in terms of the number of flare-ups and the overall control of the patient's gout. Second thing, just in terms of proactive, a flare of gout, I'd like to say that for every hour of delay in starting something that controls inflammation is worth 6 hours of more pain. So if you're on a drug like allopurinol, you're on a drug like colchicine, and many gout patients take colchicine daily, certainly during the first year that they're on allopurinol or febuxostat. The way you treat an acute flare is you take 2 extra colchicine and then 1 more an hour later. If you, at the first sign that you have an attack, you take 2 and then 1, it'll be gone in 6 hours. If you wait 12 hours, say, is it an attack? Is it not an attack? It'll take you 4 days to get better. So I think it's very important for the patient to have these tools and proactively know how to use them so that they don't find themselves falling into a hole and then having to climb out. So yeah, I hope those 2 things answer your question.
They did. Thank you. Let's continue on this thought about care. One of the biggest questions we get all the time within our support group is, who do I see? should I be seeking a primary care physician or should I be seeing a rheumatologist? What are your thoughts?
Well, first, there are a lot of primary care physicians who take care of gout and they do it quite well. But in general, when febuxostat was being studied, it was done in a comparison study with allopurinol. And the endpoint in that study was the percentage of patients on either allopurinol or febuxostat whose last 3 uric acids during this 6 or 12-month trial were below 6. And with standard doses of allopurinol, that was achieved in only 26% of patients. The standard dose was 300 milligrams a day. Mm-hmm. We know that 96% of all prescriptions for allopurinol are for 300 milligrams a day. It will control the uric acid consistently in about a quarter of the patients. So many patients need to be on more allopurinol, 400, 600. Mm-hmm. You can take as much as 800. If you're on the medicine, but you're not on the right dose, you might as well not be on the medicine. So, so I think that if 96% of the prescriptions for allopurinol were written for a dose that was only 26% effective, then you ask, well, who were their doctors? And more often than not, it was a primary care physician. So, but an educated patient educates the primary care doc to say, what's my uric acid and is it below 6? And then it doesn't matter who you see as long as they listen. And you never want to see a doctor who doesn't listen. Right. And if you've got really severe gout or tophaceous gout like you had, then being involved with a rheumatologist is probably a very good idea. If you've got day in and day out pain, 300 out of 360 days a year are challenging for you, I think a rheumatologist is what you should be involved with.
Great. Yeah, I would agree. Absolutely. So let's go to the topic of remedies and whatnot. So for 16 years, I didn't have access to medication. I had to find ways to reactively manage gout because that was the only option I had. Over-the-counter medications. My mom had, she would, because she loved me and had just, her idea is she would buy me tart cherries. Her theory was the darker the cherries, the better, right? She had me eating God knows how many yams, turmeric. I did it all. So, within our support group, we have people that are, hey, man, I'm going to do this holistically and I'm going to try to do it, with home remedies. And then you have the group that is, well, hey, I'm working with my doctor, I'm working with my rheumatologist, and I'm on 300 milligrams of allopurinol. I'm on 450 milligrams of allopurinol. I'm on, 40 milligrams of Uloric, whatever it is. But so we have almost like two camps. And what are your thoughts on the home remedies versus, healthcare options and whatnot?
Well, most people are on home remedies to control the pain. They're not on it to control the uric acid. If you don't control the uric acid over time, you're going to have more uric acid to get rid of, and whatever comes with that, which are more flares, more joints, development of tophi, disfiguring tophi. I think we all have a sense of invincibility that we should check at the door if you know you've got gout. I think, it's their saying is in poker, trust your friends, but cut the cards. So you can do all of that other stuff, but if you're not doing the basic things to control your uric acid, you don't know what your uric acid is, but you had a bunch of dark cherries. By the way, my wife has taught me how to buy cherries. Not because she has gout. I don't have gout, but the darker the better anyway. So I think that's sort of a self-serving concept of the dark cherry. They're sweeter and more flavorful.
Right.
Some people, you want to do cherry juice, that's fine. But if you've got tophaceous gout or you've had, severe gout, you need to clean out those deposits. And the only way you clean out those deposits is get get the uric acid low enough that you start to suck it back into the serum and then out through the kidneys. I see there's a question here. How long does it take when you're on a drug like febuxostat or allopurinol to stop having flares? And the answer is when the tophi go away or when the deposits are gone. Otherwise, you're going to be at risk for flares until that happens. And your goal is to take that wedge of uric acid that increases over time and change the curve so that it decreases until it's eliminated. And that if you've been accumulating for 15 years, it may take you 3 or 4 years to get rid of it. With a drug like Krystexxa or pegloticase, it may take you 6 to 9 months to get rid of it. But then you need to stay on the oral medicine as well, because nothing has changed about your metabolism. You will always have difficulty excreting uric acid. And after you have done that one trick with Krystexxa, you're just going to wind up back where you started unless you keep it under wraps. So this is a way of putting the jack in the box back in the box, and then the febuxostat or allopurinol is what keeps the latch on. It keeps the jack from jumping out again.
I love what you just said. Keep on taking the medication. One of the things that we saw often is we had people asking or making comments, hey, I've been taking my allopurinol and my uric acid has been dropping, but I am experiencing attacks. And so I think I should stop my medication until the attacks go away and pick up again. So your thoughts on that?
Yeah, it's continuity. You're lacking the ability to clear out your uric acid. So I had a neighbor, attorney, very funny guy, nice guy. He had gout and I treated him. I had him on allopurinol. He was followed by his primary care doc. 5 years later, he knocked on my door. He said, my foot's killing me. What's wrong? I said, your gout's back. He said, oh, it's not possible. So I put my heel on his foot and pressed down. He said, what'd you do that for? I said, I think you need to be on medicine for this. But he was a master of the universe and was not willing to accept the reality of his own body's metabolism. And he finally pulled himself together and got back on it and just stayed with it. For most people, it's not hard to stay with your cholesterol medicine. And this is just as important. You don't know you need the cholesterol medicine until you don't have the heart attack that you might have had you not taken it. With gout,
right,
it's going to remind you. It'll come back in a year or two if you stop your medicine.
Yeah, it doesn't take a day off, right? I tell people that as a person living with gout, even if you're not experiencing any attacks or pains, it's still there, right? And it can come back at any time. And we need to be managing this disease for sure.
So I'm looking at some of the other questions that that Robin put in. This one, I developed gout after taking a medicine to lower cholesterol. I think probably the two are not related. I stopped the medicine and my flare is better now. You could stay, if you need to lower your cholesterol, you need to lower your cholesterol. Heart attacks and strokes are bad. They're very bad. So you don't want those. But if you have another flare of gout, then if your uric acid is high, you need to bring it down. And so you have so this person's uric acid was 4. If the theory is that, gee, my cholesterol lowering medicine has caused my uric acid level to rise, then check the uric acid level again after you're back on the appropriate dose. And that should bring things under control. But if the uric acid goes up, then maybe you can draw a line of cause and effect. I will tell you, I've seen patients with tophaceous gout, never on uric acid lowering medicines, who had serum uric acid levels of between 4 and 5. So because what governs the precipitation of these crystals is the temperature of the limb. You rarely get gout in the hips and shoulders. You commonly get gout in feet. The feet are 5 degrees cooler. And if the point of saturation in the body is 6.8, it's actually in the 4s in the foot. So, so it's a little bit deceiving.
That is so good to know. Yeah.
It's simple to say that the uric acid should be less than less than 6 on treatment. But in truth, what's going on in your foot is not the same that's going on when you draw blood and you see a level of 5.8. It may not be low enough because the local factors in your feet that allow the precipitation to occur are different. There's another one, if you don't mind. After your primary doctor is a rheumatologist, the expert that treats gout. Yeah, after your podiatrist and your primary care doc, or your orthopedist and your primary care doc, if they want expert advice as to how to manage your disease, it should be a rheumatologist. We're very fastidious about these things. And rheumatology is where the patient should go if they're having trouble getting under control or they're not confident that they're getting the right advice. I will tell you that surgical types like podiatrists and orthopedists and orthopedic foot specialists do not treat uric acid. They always want a medical person to do that. And if your internist or family doctor is tuned in, they'll do the right thing. And your job is to tune in. It's part of it because they may need to.
Right.
Are you seeing the chat?
I am. I'm seeing it. So let's go. I have a question here about comorbidity with gout.
Yeah.
You talked, one of your slides, you talked about how, it affects kidneys, maybe your heart disease, cardiovascular, diabetics, or diabetes, and you have sleep apnea in there in one of your slides. That's interesting because I actually went through, because of uncontrolled gout, I could not sleep, I developed sleep apnea. So which is it, like if someone has kidney disease, did that cause gout, or did gout come first and, it caused their kidney disease? Chicken or the egg? What are we talking about?
It works both ways. It works both ways. So if the kidneys are malfunctioning, they don't handle uric acid effectively. If you have a genetic defect in the kidney that causes uric acid to rise, even with normal kidney function, otherwise normal kidney function, that's a factor. And then you may have tophi in your joints. You can also develop these deposits in the kidney and add to kidney dysfunction. There are 4 different ways that gout affects the kidney. First, it's associated with hypertension and hypertensive kidney disease, because hypertension is very common in the gout population. Probably 40% of patients with gout are hypertensive. 30 to 40% of patients with gout have renal insufficiency, have kidney disease. 20 to 25% have coronary disease. There was an interesting study with teenagers who had elevated uric acids and were hypertensive. And they treated them with allopurinol to lower the uric acid, and their blood pressure normalized. So chicken and egg, I don't know, but there is some feeling. The next question is, well, if your uric acid level is high, and this is what most physicians will ask in these types of programs, if your uric acid is high, I lost my train of thought, and you lower it, do you lower the risk for heart disease? Do you lower the risk for high blood pressure or kidney disease? And the answer is we don't know. So it's not recommended that someone who has a high uric acid who hasn't had gout should be on medicine to lower the uric acid. It's not clear. It's not currently recommended. It would require an enormous study to reach that conclusion. And I should add that just because these medicines are effective doesn't mean that there aren't some adverse reactions that you'd want to avoid. So some people, for example, can develop severe allergic reactions to allopurinol. And so you want to make sure if you're on allopurinol, it's something you need to be on.
What do you say to patients that might not be able to take the 2 most common medication for managing uric acid? We have allopurinol, Uloric. Hey, Gary, I'm allergic. It's causing me rashes. I'm not able to take these medications. what other options might we have for people like that?
First, those when a patient is in that situation, I want to verify that history for sure. There are methods of desensitization where you give a very low dose and then you gradually increase it to tolerance. And a patient who may have had a rash or reported a rash may be able, if you do it that way, you might be able to get away with it and reinstitute the medicine. So, there's not a set answer for that. If patients are truly allergic and they have abnormal kidney function, then that's a difficult situation. Krystexxa, like you mentioned, is a huge time commitment, and it's exceptionally expensive. And even if you're insured and your insurer or the government is paying for it, it's still it's a last resort, and it's not meant to be a lifelong treatment. There are rare situations where it might be necessary, but it's rare.
Gotcha. Now, you mentioned about when it comes to diet, you mentioned alcohol. I remember when my gout was out of control, beer was up there for me. Over time, I switched from beer to maybe, I think I started drinking vodka and tonic, right? I'm thinking that might be better. Now I don't drink much at all, but what are your thoughts? Are there other options that are better than beer?
Well, the answer is the best time to drink alcohol is 1 glass on your birthday and 1 glass on New Year's Eve. Maybe half a beer on July 4th. Certainly, until you're a year away from your last attack, I would avoid those. You can drink in moderation once everything's under control, in moderation. There are studies done retrospective. It was called the Healthcare Professionals Study, where they looked at people who were males in the healthcare sphere, and they followed them over a long period of time. And they divided drinking into light, moderate, and heavy. And they looked at what people drank and how they classified them as light, moderate, and heavy. And beer looked worse than spirits, and spirits looked worse than wine. But I don't think it was a particularly good study, because the cutoff for beer or wine or spirits was 2 glasses a day. And most beer drinkers, finish off a 6-pack with one sitting. And that wouldn't be picked up, with 2 glasses a day. Wine drinkers rarely get more than a bottle. They usually share it. And spirits, beer drinkers tend to, a glass of wine or a shot glass of a spirit or 8 ounces or 12 ounces of beer, they're roughly equivalent per serving in terms of the amount of alcohol.
Great. Now, we had talked a little bit about comorbidities earlier on. You talked about high blood pressure medication, like diuretics that can lead to gout. Could you talk about other comorbidities that might come up with gout?
What do you have in mind? What other disorders? So these are, these.
What about heart problem?
Well, so first, the increased risk of heart disease in patients with a metabolic syndrome. Second, patients with heart disease, heart failure, are on diuretics, right? So, and diuretics cause the uric acid to rise and increase the risk for gout. Now, if you need to be on a diuretic, you need to be on a diuretic. You just need to control your uric acid. So, if that's the best medicine for you. So, but those diabetes, obesity, sleep apnea, hypercholesterolemia, renal insufficiency, they all travel together. So if you look at the 18th century cartoons of the gout patient. It's always someone who's very heavy, their foot's wrapped up in a plaster, there's a glass of port wine at their side, and a pipe, and little children running around making fun of him. This is that ashamed part that you talked about. That's the characteristic. You're a thin guy and you had gout, so that's clearly a genetic issue. I had one patient that we put in the very earliest Krystexxa study. It was phase 2. There were 40 patients in 8 locations around the country. We had 6 of them. And he was planning on having bariatric surgery, but he was so troubled by his gout. He said, I'm going to put that off and I'll go on this medicine. And he was on it was a dose finding study, and he wound up on the right dose. And over the course of 3 months, it was just a 3-month study, all of his tophi went away and his joints felt better. And he had his surgery. And this man was about 5'2" and 250 pounds. And we sent him out and brought him back about 12 months later, and he was 5'2" and 145 pounds. And the company that made Krystexxa at the time, pegloticase, was curious about whether you could treat somebody a second time or not, because the medicine you're on causes antibody formation, and it's rare that you can take it a second time because you become allergic to it. And we couldn't qualify him for the study because his uric acid never went higher than 5. It had been 8 and 9 originally. So he lost 40% of his body weight and cured his gout. But I think that's unusual. Most people can't lose 10% of their body weight and keep it off.
So we have a question here. A gentleman had asked, what about a case where someone is taking Uloric and their uric acid level drops to about 4, but they're still experiencing attacks? What do you say to somebody in that situation?
Well, it hasn't been to 4 long enough. So again, you're salt mining. You're gradually cleaning out these deposits. If you're seeing a rheumatologist who knows how to use ultrasound, they can look at your joints and they can actually see the uric acid in the joint and on the cartilage. Painless procedure, just bounce sound waves off of it and get an image. It's clearly going to be there. And if you're on Uloric and your uric acid is 4 and you're still having flare-ups, you most certainly should be on 1 or 2 tablets of colchicine every day.
Gotcha.
And that'll control it. And then if you have a flare up, first inkling, 2 extra colchicine, and then 1 an hour later. And you're good to go. And that's what we talked about earlier about, being proactive, having that tool in your medicine chest to use, knowing when to use it. To me, failure in managing gout may be one lack of recognition, but on the other side, I think it's a very simple disorder to manage. But on the other side, it's an educational failure. If the patient understands how it works, and that's why I break it down into a metabolic disease and an arthritis, and to see the relationship between the two, you can't control the arthritis fully unless you fully control the metabolic disorder with the uric acid lowering medicines.
I have to say, I mean, when it comes to gout, we don't live in a better time to have gout. I would think, I'm not a medical professional, but I would think we have more options now than when Benjamin Franklin was alive with his gout, right?
Well, have you ever read his treatise on the wrestling with the gout? He wrote an essay about his dealing with the gout, and he framed it as a fight, a physical fight, where the gout had a personality and he engaged in fisticuffs. But that that may be so, but there are still a number of new drugs that are being looked at. There's another drug like Krystexxa that's about to be put before the FDA in the next 6 months or so. And there are drugs in the probenecid class, and there are other xanthine oxidase inhibitors, all of which are viable candidates to be made available. So when you describe the person who says they have an allergy to allopurinol and febuxostat, there are other things coming around the bend that might be useful too.
Great. So in the sake of time, I think we're running low on time right now. What we'll do is we're going to wrap up. I'm going to ask you, as we're leaving tonight, what is something that you would want to leave our audience with, a thought about gout? What's your one thing that you want to leave?
Digital producer here. We do have a few questions.
Oh, okay, Robin.
We do have a few questions from the chat, so I just want to make sure that we answer those attendee questions first. So Dr.
Oh, sure.
Yeah.
I looked at the one at 712 about relationship between inflammatory conditions and gout.
Yes.
We talked about that. And can you be diagnosed with gout on febuxostat with good uric acid control and still have joint pain? We talked about that. It's a matter of cleaning out these crystalline deposits, and it takes time, and you can actually see them under ultrasound. And then this person said, if I might have rheumatoid arthritis that also runs in my family, can you have gout and rheumatoid arthritis? You can. It used to be said there was a negative association. People with gout don't get rheumatoid arthritis. And I recall a funny vignette. A patient of mine who I'd managed for rheumatoid arthritis and whose twin sister had rheumatoid arthritis came in with, I don't know if you can see me, came in with a rupture of the tendons in her right hand. These fingers wouldn't come up. And it was due to what we commonly see in rheumatoid arthritis. The joint lining eats through the tendons, saws through them, and the tendons are no longer, the muscles are no longer attached to the fingers. So I sent her to a surgeon to have that repaired. And when he opened up the hand and pulled the skin back, he found gouty material. So she had gout. And I said to my partner, we want to write this up. It's supposed to be this negative association. And he said, yeah, you can write it up, but your colleagues will think you're an idiot. Well, it's not, the two do coexist. I've seen it many, many times, at least a dozen times over a 30-year period. And then, of course, there's rheumatoid arthritis that looks like rheumatoid arthritis, but it really is gout. And it doesn't respond well to treatment for rheumatoid arthritis. So I think the value of seeing a specialist is that they think about these things all the time. And if they're a good specialist, they think about it and then they rethink about it. And each time they see you, maybe it's a little bit like Groundhog Day, where they just go through, well, what am I missing here? And have enough experience to be able to recognize the telltale signs of what they weren't suspecting in the first place.
Perfect. Robin, do we have any other questions before we kind of wrap up?
Hi, yes, Gary. There's one in the chat. I'm not exactly sure what this person means, but they said, if you go to the ER or doc when you are in the midst of a flare, and I'm assuming gout flare, they asked, will your uric acid levels still register as high? And I assume so.
Yeah. So
that's a good question.
Yeah, and the answer there is that first, your uric acid doesn't have to be high when you're having a gout attack. And in fact, it usually is about a point to as much as 1.5 points lower than what it would be when you're not in the midst of an attack. And the reason for that is that, these attacks are intensely inflammatory. And what that means, not only that they're red and swollen and tender and the joints are difficult to move, but it also means that there are substances in your body that are going to that foot that are produced in abundance. And one of those substances is a substance called IL-6 or interleukin-6. It has an effect on enhancing uric acid excretion by the kidney. So the inflammation itself may lead to a transient lowering of uric acid. So textbooks will tell you, most articles, comprehensive articles on gout will tell you the worst time to check a uric acid is during the midst of a big flare.
Mm.
So you're not crazy if you think you have gout. There are better ways to know for sure that you have gout. Putting a needle in the joint and seeing and pulling out the material, looking under the microscope is one way. Ultrasound is another way, which is not as painful as a needle. And you can have a degree of certainty, in fact, a greater degree of certainty now than we could have 15 years ago, for example. There's also a test like a CT scan. It's called a dual energy CT scan. You can actually see the tophaceous deposits and measure their volume, and they show up as a special color. You can create 3D images, and you can get a very, very specific and characteristic appearance. So there's new things all the time, and getting yourself, if you're at all confused about what you're hearing and unclear, seeing a rheumatologist is probably worth your while.
Great. So let's go ahead and wrap things up. Thank you so much for joining us tonight. And I'm going to leave it to you to give one last nugget of truth for our listeners tonight before I just kind of go through and wrap things up.
Consistency. That's it. If you're doing it right, keep doing it. Recognize that there's something wrong with your metabolism. And if you let up, you lose. So once you're on a medicine like febuxostat or allopurinol, it's for life. And stay with it. Unless you lose 40% of your body weight. Stay with it because it's going to come back to haunt you if you do. And if you're consistent, you'll be successful.
Great. Thank you so much. Pleasure. Okay, so we're going to wrap things up. Upcoming events and resources. We have, you can go to our webinar and look at, you can actually go to our website and look at our webinars and look at our podcasts. You can go to arthritis.org/webinar. We have a military and arthritis mental health and pain connection, September 14th from 7 to 8:15 Eastern Time. We have Real Talk, Real Solutions for Chronic Pain, September 21st, 6 to 7:15 p.m. Eastern Standard Time. We have an upcoming Walk to Cure Arthritis. It's that time of year. Go ahead and pick a team. Get some people together, gather a team, and go to the website at arthritis.org/WTCA and see where the event is closest to you. We have the Live Yes podcast. You can find it at arthritis.org/podcast. And this is kind of neat. The Arthritis Foundation has, again, a helpline. They're manned by live people that can actually walk you through, answer questions about arthritis, answer questions about gout. And actually, if you're having problems navigating through your insurance, they can help navigate too. So that's actually awesome, honestly. And then lastly, we will be sending out a survey for you. Please take time to complete the survey. The survey will honestly help us to better with our future podcasts and webinars. We have a Live Yes Connect group for gout, connection or connectgroup.arthritis.org/groups/gout. Saturday, August 19th, 7:30 p.m. Eastern Standard Time. Saturday, November 18th, 7:30 p.m. Eastern Standard Time. Lastly, I'm going to leave you with my nugget of truth. please go ahead and if you want to find out more about the Gout Support Group of America, the support group that Dr. Parker, my rheumatologist, and I created, you can find us at goutsupportgroup.org on the internet, or you can find the Gout Support Group of America on Facebook. Feel free to request to join, and we'll be happy to allow you to join. And then one last thing I want to leave you with, as I lived with gout for the last 29 years, I'm going to say this. When it comes to gout, you manage gout or it will manage you. Thank you so much for joining us tonight. And we want to thank our sponsors, Horizon Therapeutics, for putting this event on. Take care. Bye.